Jabbar from Trivandrum. Dev is there, Dr. Shaila Sheikh is there. Speaker, Dr. Prakash Abra. Thank you all of us, for all of you, please, for joining us, and maybe we'll go live in 1 or 2 minutes. Raghu, are you ready?
We are ready. We can go live anytime you say.
Yeah, Dr. Sanket, please go ahead. Raghu, could you mute all of us and unmute then as per your wishes?
Sure, I'll give you a countdown so you can start.
Speaker, Dr. Prakash Abra.
Your countdown of
Thank you all of us, for all of you, please, for joining us, and maybe we'll go live in 1 or 2 minutes. Raghu,
good evening, everyone. I welcome one and all to ProCare HD's SEED, a scientific program provided by Macleods Pharmaceuticals. SEED is an international speaker program which stands for Cases, Evidence, and Experience in Hypothyroidism. SEED is an initiative taken by us with an intent to share knowledge and delve deep in hypothyroidism. I am Dr. Sanket Nevale, representing Medical Affairs at Macleods. With me, I have Mr. Abhijit Ganguly, who is leading the sales and marketing team at ProCare HD. Today, we have blocked our calendars to be a part of yet another event at Macleods called SEED, which is a 2-day, 2-hour event planned for 7th and 8th November, that is today and tomorrow, between 6 and 8 p.m., where eminent speakers from national and international will be sharing their vast experience and learnings in the field of thyroid management. Now, I would like to introduce the chairperson for today evening, Dr. P.K. Jabbar, who is MD, DNB, DM, DNB, FRCP, and Professor and Head of Department of Endocrinology, Director and CEO of Indian Institute of Diabetes, Trivandrum. He's been the chair of ESICon 2017, organizing secretary RSSDI 2010, contributed to textbooks medicine, 35 papers in journals, presented papers in various endocrinology meetings, regular examiner for various universities, and medical council inspector. So without any further ado, I would request Dr. Jabbar to take over the session. Sir, over to you.
Am I audible, Dr. Sanket?
Yes, sir.
I said very good evening from God's own country, Kerala. Okay. Good evening, special good evening, and welcome to my friend Dr. Prakash. He's from my own place, from Trivandrum. Okay, I think I'm audible, right? Dr. Prakash, am I audible?
Yes, sir, you're audible and clear, sir.
Okay, that's fine. Okay. And special welcome to my friend from Trivandrum, Dr. Prakash Abraham. First of all, I should thank the Macleods Pharma for providing a wonderful platform for exchanging our ideas in the field of thyroid. As you all know, see what we are planning for 3 sessions. International speaker is Dr. Prakash, and we have 2 speakers, one from Mumbai, another from Bangalore, very eminent and good orators in the field of thyroid and clinical medicine. And first we have the international speaker by Dr. Philip Abraham. Probably you know the profile of Dr. Prakash Abraham. Basically, he is from Trivandrum. Now he's practicing at Scotland. Now, currently he is heading the department in Aberdeen Royal Infirmary, Scotland, and is a very, very active member in the Thyroid Society, British Thyroid Society, since last probably 17 years, and is a member and a very steering person for the Society of Endocrinology UK and American Endocrine Society. So lot of credentials for Dr. Philip. I think I should be very proud to introduce one of the person from Kerala with this much of credentials, and he's having lot of publications also. At least I can see 40 publications and lot of abstracts in various conferences. I don't want to waste my time again and again. I invite Dr. Prakash to deliver his talk, and he'll be presenting a few cases for today, and tomorrow also he'll be discussing few cases. Over to Dr. Prakash, please. After this session, we'll have a sessions for discussions also. You can post the questions in the chat box. We'll read it, and Dr. Prakash will try to answer the question. Over to Dr. Prakash. Thank you very much. Have a good day.
Thank you, Dr. Jabbar, for your very kind introduction. I'm very pleased to join this very eminent panel of thyroid experts from India. I obviously am very fond of any interactions that I have with the Indian colleagues and at Indian meetings, and it's a pleasure to join. Despite the fact this is a webinar platform, I'm sure we can try and do our best in getting some of the cases discussed and an exchange of ideas. So I'm just going to share my screen and hope this works. Right. Okay, so this is the topic is over the next couple of days is complexities in the management of hypothyroidism, and we chose about 10 cases which I have managed over the course of the last 15-20 years in Aberdeen, which sort of reflects the spectrum and the breadth of some of the challenges in managing hypothyroidism. So I work in Aberdeen, which is about 2 hours north of Edinburgh by train or by taxi, and is about 8 or 9 hours from London. So Aberdeen, the University of Aberdeen is actually one of the oldest universities in the UK. It's the third oldest university in the UK, established in 1495. And one of the things we are proud of in Aberdeen is that this was the first medical school which was taught in English, because in the world, that is, because Oxford and Cambridge, which were the older medical schools, had their teaching had a chair of medicine in Latin. So Aberdeen actually has that sort of fame attached to it. I'm also proud of our center, the Diabetes and Endocrinology Center, because this is the J.J.R. MacLeod Center, which is named after J.J.R. MacLeod, who's the Nobel Prize winner for discovery of insulin, and he is an Aberdeen graduate. And we, in fact, have the Nobel Gold Medal in our university collections. So that's something we also take quite a bit of pride about. So going on to the cases, we have divided the cases over the 2 days into part 1 and part 2. I understand that the audience is a range of audience, including general physicians, diabetologists, and of course, endocrinologists as well. So hopefully the cases will appeal to a range of you, and there'll be something to learn from each of these cases as we are taking through them. So the first 5 cases are, I'm starting off with a very simple dose case, but again, even from that, there are changes in practice which have happened over the past few years. I then tackle subclinical disease, and then a very common problem, which is symptomatic disease, patients who are treated but are still symptomatic. And particularly in the West, this is a significant issue among what we choose and what alternatives we can use for that. High dose and how we respond to that is another case. And then finally, this session will be testing malabsorption. Tomorrow, we move into a few more cases, which some of them will be a little bit more fancy. Immune checkpoint inhibitor disease is now getting to be a big problem now. It's now a regular form of referrals for us. We'll discuss that. And then also common scenarios which could be mistaken for hypothyroidism, which may actually be needing further investigations. So that will sort of cover a fairly large range and breadth of challenges of managing thyroid, hypothyroidism, and funny thyroid function tests. Some of the key references which I include, particularly the one would be the NICE guidance, which is our National Institute of Clinical Excellence guidance on thyroid disease and management. This was in 2020, so it's a very current guidance. So that is something I've referenced a few times. The management of primary hypothyroidism statement by the British Thyroid Association Executive Committee, of which I was a member at the time of that statement, was in 2015. And then I've also discussed our contribution to what can occur with patients on high levothyroxine dose. Initially, when you're a sort of trainee, you think hypothyroidism is very easy. You just give some thyroxine, very straightforward. I think as I've done more and more years of practice, this quote from Socrates comes to mind: "The more I learn, the less I realize I know." And I suspect this will certainly resonate with those who have been practicing in the field for longer and longer. There are new molecules been discovered. There are various pathways, transporters. All of this are there to confuse us and and we include that in discussions with patients and others. So let's start with an easy one. Case one, kickstarting, just how to kickstart dosing. So this is a 55-year-old female who reports about 6 months of feeling tired, a hoarse voice, and dry eyes. Typical symptoms, but not always addressed or tackled appropriately. So this patient went to her GP, general practitioner, and as she was having a sore throat and hoarse, she was referred to ENT, who did an endoscopy. She then went on to have speech and language therapy. Because of her dry eyes, she was referred to an ophthalmologist. And again, the ophthalmologist gave us some, sort of eye drops and other things. Unfortunately, nobody so far had done a thyroid function, which is strange. But considering we do so many thyroid functions annually here, the GP did not do that immediately. And then about a year later, the patient was admitted with what was considered to be a heart attack, a myocardial infarction, because she had chest pain. And one of her creatinine kinase was 2000, which is about 10 times normal. She had classic hypothyroid features, and her TSH was more than 150 with an undetectable free T4. So it was not a heart attack, it was just severe hypothyroidism. And you can see some of the classic responses which can occur. We just gave her 3 months of treatment with levothyroxine, started with 25 and then put it up quickly to 75. And within 3 months, TSH went down from 150 to near normal, 6.1. Normal range for us was 0.35 to 4.5. A free T4 became normal. A creatinine kinase normalized. Her liver enzymes AAT normalized. Her cholesterol, which was 9.6, came to near normal at 5.3. 5.2 was our upper limit of normal at the time. And the sodium. So cholesterol is because hypothyroidism can interfere with metabolism of cholesterol, and that's the reason for that. And sodium is high because hypothyroidism can cause SIADH, syndrome of inappropriate antidiuretic hormone release. So again, a few months of treatment, the sodium normalized as well. So this is just a classic case, which hopefully we will not see too much of, but because more and more people are testing before that. So this is our Grampian guidance. So we have for the region, Grampian region, which is about a population of about a little over 500,000. We have our guidance on the intranet, which is based on the NICE guidance. So this is just a few snapshots from that. So these are the typical symptoms and signs. Symptoms being fatigue, feeling cold, weight gain, etc. And signs, coarse, dry skin, swelling of the eyelids, vocal changes because of thickened vocal cords, bradycardia, hypertension, typical delayed relaxation of deep tendon reflexes, and paresthesias due to carpal tunnel syndrome. There is a large overlap of typical hypothyroid symptoms with the euthyroid general population, but it's a simple enough test to do. So obviously, if it presents anything, you would arrange to test it. The thyroid function, simple to do, TSH and free T4. Consider testing other factors of the presentation for blood count, glucose or HbA1c if they have symptoms. And this is, I've borrowed a few graphics from my friend and colleague, Professor Mark Gunnell in Cambridge, and this is from his publication. So the pituitary thyroid axis is very sensitive. So I've just shown, I'll build up on this graphic over the course of the cases. So when you have a normal individual, TSH is normal, free T3 and free T4 are normal. And then when you have classic cases of hyperthyroidism, the TSH is suppressed, free T3 and free T4 is elevated. And a classic case of hypothyroidism, the TSH is elevated and free T3 and free T4 is low. And as I say, I will build on this diagram as we go through the cases, and hopefully I will complete the full circle by the end of tomorrow. So these are a couple of questions. As I say, initially we were hoping it would be interactive, but clearly the webinar is not something which can lead to an interactive session, but it'll be useful to just have a minute to think about this. So would you start levothyroxine for a typical barn door case of hypothyroidism, levothyroxine 50 micrograms daily and check in 2 months. Start 50, increase to 75 after 2 weeks. Start 50 and increase to 100, I think is a typo, after 2 weeks. And start thyroxine based on weight. Start thyroxine based on TSH level. So there are a few different ways of doing that. And the NICE guidance has changed my practice. So in the last couple of years, I have changed my practice of that. I would perhaps have been starting closer to sort of a B or C, depending on the weight. But the NICE guidance has changed that, and I'll tell you how. So the NICE guidance has come up with this: overt hypothyroidism, adult less than 65, start levothyroxine at 1.6 micrograms per kilogram, rounded to the nearest 25 micrograms, and titrate in 25 microgram steps according to TFT results. Adults more than 65 or with pre-existing cardiac disease start at 25 to 50 micrograms, and again, titrate in 25 microgram steps. Measure TFTs every 3 months until the TSH level is stabilized, and do the thyroid peroxidase antibody only once. A couple of very simple but important things about levothyroxine. Again, which is levothyroxine should be taken first thing in the morning. It can be taken in the evening as well. It should be swallowed with water on an empty stomach. And as I say, there is evidence that you're fine taking it last thing at night, 2 hours after your evening meal, if that is more suitable for you. A number of things can affect the absorption, food, supplements, etc. So that and compliance needs to be stressed. And if symptoms persist, one can aim to maximize the dose in smaller changes while avoiding TSH suppression. Now, why this recommendation? Why was this changed? And partly this is because we have one prospective double-blind trial, which is published in 2005 of about 50 patients. Thyroxine was given as liquid at bedtime, and the thyroxine dose adjustment was made every 4 weeks. So clinical assessments were done every 4 weeks, cardiac assessments at 12 and 24 weeks. So this is how the groups divided. Full dose was about 25 patients, age and TSH were similar, and low dose was 25. And there was no significant difference in time for hypothyroid symptoms to recover. And at the end, you can see that the full dose patients just achieved that quicker. So the full dose patients achieved, most of them achieved, majority achieved normalization of TSH and free T4 by 13 weeks, whereas by 8 weeks, most of them were normal. And even at 4 weeks, more than half were normal. Whereas when you low dose, hardly anybody achieved normal TSH and free T4. So this is just that showing graphically. You can see the full dose achieves a normal far quicker. And this is the thyroxine dose. So rather than build up the dose over time, you can just build it up quicker with it. So the main point to make from this is that, yes, you can start slowly and the outcome is the same, it's safe. But the point to make is sometimes patients will suffer for longer. So this is in a trial and you would have been prompt about changing the dose every 4 weeks. But quite often you leave it 3 months, you leave it 4 months, maybe even 6 months before the next dose change happens. So you're much better off going for the dose quickly and then adjusting thereafter. So moving to a second case, and as I say, we can happy to take questions at the end of the 5 cases. Any comments or questions anybody wants to put a chat about that. So this is a subclinical case. So a patient, 32-year-old, some tiredness over the last 6 months, no weight change, no family history, TSH slightly elevated, free T4 15. So as I say, moving into the subclinical spectrum, you can see that the TSH is elevated, free T3, free T4, subclinical hypothyroidism. So again, similar sorts of questions as before, start slow or start LT4 based on weight. And again, the NICE guidance actually suggests that if you're deciding to treat, you will treat as for overt hypothyroidism. Give a 6-month trial and see if there's a response. So if the patient is under 65, patient has symptoms, if the repeat TFTs continue to show subclinical hypothyroidism, you would repeat once, you would not start treatment based on a single test. If the TSH normalizes, then nothing further. But if the TSH remain in the subclinical range, you would consider a 6-month trial as you would for overt hypothyroidism. And again, the rationale is that if you're giving a dose, you may as well give it at the full dose so that you will know whether the trial has been successful or not. And again, this has been maybe a slight change in practice, because otherwise previously you would have been starting at 50 and things like that. So the NICE guidance has made a change in practice in this as well for us. So even, as I say, a simple thing like dose, we have changed and evolved in the past few years how we would address that. Monitoring, of course, is once things are stable, just an annual monitoring is all you need with that. Now we go on to slightly more challenging scenarios. Symptomatic patients who are still feeling that they are symptomatic after receiving treatment for a while. So this is a 43-year-old woman, hypothyroid for the last 6 years, on levothyroxine 125 microgram per day. TFTs were normal, and she's still complaining of tiredness, weight gain, and dry skin and constipation. Now, this is because there's a lot of overlap between patients who are euthyroid and patients who are hypothyroid. And when you have a condition, you would not naturally think that everything is due to your thyroid. So you can actually see in the darker gray is the euthyroid patients at a Colorado State health fair, and then those with elevated TSH. So you can see that many of the symptoms, there's quite a significant overlap between patients who are euthyroid and patients who are hypothyroid. So if you ask 100 people on the street, how are you feeling? Do you feel a bit tired today? Is your skin dry? About a similar proportion will answer that. And again, this is it's showing up here for patients who are euthyroid, in white, subclinically hypothyroid in the darker color, and hypothyroid. So you can see that this is the number of patients with 0 symptoms, 1 symptom, 2 or 3 or 4, what we would class as hypothyroid symptoms. And again, you can see a significant overlap between that. Now, this has been a source of significant issues, particularly for the West, for our grouping, because there are patient groups and others who advocate strongly for medications which are quite a bit more expensive, and which would be, in a public health system like ours, patients, if it's agreed to be treated, then we have to bear the cost of it. So I don't think that's a problem so much in India, because I don't think LT3 or liothyronine is marketed much, but somebody can correct me at the end. But out here, liothyronine costs nearly 50 times what levothyroxine costs. And there's a lot of patient lobbying. In fact, the Scottish Parliament has been involved in this with lots of discussion about it. And the end result is that we now have to at least consider giving liothyronine for some patients if they continue to be symptomatic. But before we come to that, these are some of the other causes for persistent symptoms that we have to consider. We have to consider, obviously, adrenal insufficiency, hypopituitarism. I marked the more common ones in yellow: celiac disease, anemia, vitamin B12, vitamin D deficiency, poor sleep pattern, chronic fatigue syndrome, etc. So we need to exclude all of these before we go with that. So we then have a protocol or a pathway for using combination trial treatment with T4 and T3. We state that it should not be used routinely in the management of hypothyroidism, as there is insufficient evidence. In addition, there are concerns that T3 may result in potential bone osteoporosis and cardiac issues. We agree that there's a small subset who do not feel well and who wish to access T3 combination treatment. And there are guidelines, the American thyroid guidelines and the European thyroid guidelines, suggests that it can be used as a trial, carefully supervised by a consultant endocrinologist. So again, we give this to the patient, a 2-page document. What are the possible causes of hypothyroid symptoms? And I already discussed that. We discuss and cover these. And then if the patient is still very keen on having a trial, we give a 3 to 4 month trial of combining liothyronine and levothyroxine. So for somebody who's on 100 micrograms a day, we would subtract 50 micrograms of levothyroxine and use 5 microgram T3 twice daily. And similarly, depending on the dosing being higher, we would use different dose frequencies. So this is again something which we have had to adapt and change, because until about 4 or 5 years ago, I would never use levothyroxine in my routine management. And in Grampian, we have a very detailed database. I look after about 22,000 patients with hypothyroidism in my region. And because all of it is centralized, I know the information, even though the patients may be looked after by their own GPs, we do have the information as how they are doing. So until about 5 years ago, I've never used liothyronine, but because of these pressures from Parliament and others, all the health board has had to adapt and at least offer this to a small proportion of patients for that. So we are doing that, and there is a proportion of patients who feel wonderful when you use liothyronine, and there are some explanations for it. There may be a small number of patients who may not convert T4 to T3. The T3 is the active component of thyroid activity. There may be problems with deiodinase enzymes, etc. So there is a rationale, but as you may know, a number of trials, in fact, there have been 13 trials so far, which have not shown a clear benefit on which patients will benefit from combining T3. So the current policy is to just minimize the number used, and hopefully over time we'll have more evidence for that. If it hasn't yet come to be an issue in India, it may come to be an issue, but obviously the fact that patients are paying for their own medications mean that they will continue the medications only if they feel so wonderful about it, whereas it's slightly different here. Case 4 is what we do with somebody on high doses of levothyroxine. So high doses is defined as over 2 micrograms per kilogram or 200 micrograms per day is what we would roughly use that. So this is somebody who is hypothyroid for 5 years and is on 250 micrograms daily. So this is again from our same guidance. So things we check: compliance. It's easy to forget a dose or 1 or 2 doses a week. And if you think that you miss 2 doses a week, that's almost 20% of your dose. So 20 to 25% of your dose. So that's something which we have to make sure that the patient is doing. Timing of the dose, that's important. Again, everybody lives busy lives and not always can they remember to take the dose at the exact time. Avoiding other medications, particularly as you grow older, you increase the number of medicines that you end up taking, cholesterol lowering, vitamins, etc., etc. So combining medications can cause that. And there are some medications which can cause it more, particularly calcium and iron supplements. Medications that increase metabolism of levothyroxine, rifampicin and carbamazepine. And any symptoms of malabsorption, etc., should be considered as well. So we do all these, and we did a large audit of our patients. And as I say, at that time, we had 17,500 patients in our list of patients who we call the Grampian Automated Follow-up Register. This was set up actually in 1967 in Grampian, where all the patients who are hypothyroid are registered, and we have an idea of how they're doing. So in 2008, when we did the audit, 1% of the patients were taking more than 225 micrograms of levothyroxine daily. So 190 patients, or 1% was doing that. We then did a questionnaire study and contacted 174 of them. And each of them we did antibodies for celiac, parietal cell antibody, and thyroid peroxidase antibody. The mean levothyroxine dose was 248 micrograms daily in this group. And then what we found out was about 20% took interfering medications. about 17% had compliance issues, and then a small number of patients had celiac disease or parietal cell antibodies, so about 20%. So these are certainly things that we would address, and once we addressed it, we found that doses did decrease in some of these patients. So this is something which is worth doing and considering if you're having a large cohort of patients. So common factors that can increase levothyroxine dose requirements are, again, I've highlighted the more common ones: medical conditions like celiac disease or atrophic gastritis. Even coffee, if drinking coffee has been proven to interfere with levothyroxine. Medications which interfere with absorption include proton pump inhibitors, iron, calcium, and then medications which increase metabolism. So these are something that you would consider when somebody's got that. But as I say, the top ones are compliance, timing of dose, interfering medications. Finally, case 5, testing malabsorption. So this is a 42-year-old woman referred as taking levothyroxine 450 micrograms daily and still being subclinically hypothyroid. The weight is 97 kilograms and denies any obvious malabsorption. Celiac serology was okay, was negative, vitamin B12 okay. So we do a test called a thyroxine absorption test. So I will come on the protocol about the test in the next slide, but these are slides from that paper. So at the end of in the initial test, when you give a big dose of levothyroxine, about the free T4 increases by about 54%. And then this is a test which lasts about 5 weeks. The TSH should fall by at least half in 75% of the patients. So that's the sort of graphics for the test. So this is the protocol for the test. Before doing the test, you exclude causes of undertreatment, such as some of the things which I've discussed already. On the day of the test, the patient is fasting from midnight, and you give a week's dose of levothyroxine in a single dose. We actually give it as a calculated dose because obviously if I give 450 into 7, that's a massive dose. We actually do a calculated dose of 1.8 micrograms per kilogram. And we usually crush it and give it with honey or jam, something like that, so that it's, and then that is swallowed down. We check the thyroid functions at this time specified every half an hour or so for about that period of time. And then after that, they come for a weekly supervised administration of the same dose of levothyroxine for 5 weeks and 60-minute observation. And we collect the blood samples for the thyroid functions. And then following that, we decide whether there's a true malabsorption or not. So I'm going to give you an example of one of the patients that we did that for. So this is a patient, in fact, the patient I referred to. So we calculated, so the patient was taking a daily dose of 450 or claiming to take a daily dose of 450 micrograms per day. So that would be about 3 grams, so 3,000 micrograms or 3 grams weekly. We calculated the weekly dose based on the weight to be about 1,200 micrograms, and that's what we gave. So we give a single dose of 1,200 micrograms. You can see the TSH over the 4 hours of the test came down from 16 to 8. That's and then the free T4 went up well over 50%. So the mean increase is 50%. In her case, you can see it went about 250% higher. So that clearly shows she doesn't have a problem with malabsorption. We monitored her heart rate and blood pressure. They were fine. And then the next 4 or 5 weeks, she came and had a weekly dose. And by the end of the 4 weeks, you could see that even that dose, she managed to normalize her TSH and in fact suppress her TSH with normal T3 and T4. So this is from my letter. The results are included below, and you can see that the free T4 went up from a baseline of 14 to a peak of 42 on the first day. It shows she had an adequate absorption of a levothyroxine dose. By week 5, the TSH had come down, and this proves that a weekly dose is more than adequate. She lost about 4 kilograms in that period, feeling much better, and she realized the importance of taking a medication. So then what we did was we placed a weekly dose in a labeled box every Sunday and ensure the tablets are consumed over the course of the week in 2 or 3 split doses. And this is a blood test 2 years later on the same dose. So essentially, in fact, the majority of tests we do, we actually find there's a compliance problem rather than a malabsorption problem. And sometimes all we're doing is proving it to them, saying that we have taken it seriously. We've proven that there's no malabsorption, and this is the issue with that. So the learning points from these cases: case 1, as I say, kickstart dosing. Consider starting higher initial dose as per recent guidance, and certainly we have started doing that. Case 2, subclinical, trial of treatment of a good dose for 6 months as above. Case 3, consider the other conditions, optimize therapy. High dose, case 4, consider drugs, compliance, malabsorption. And then case 5, we discussed the testing malabsorption protocol. Thank you for listening, and happy to take your questions and discussion.
Oh, it was a wonderful presentation. It was a brilliant presentation by Dr. Philip. And it's very clearly conveyed the messages also. That is most fascinating for me. As a teacher, I can tell you one of the best presentation I've ever heard now. And see, we also did the dynamics, the thyroid absorption test. So we found it is the most common cause of this resistant, so-called refractory hypothyroidism is non-complaints. Okay, and anyway, see, so one of the best presentation very clearly conveyed the message. Straight away we'll go for the questions. Questions are very interesting questions. First question: how do you recommend the dose of thyroxine in a newly diagnosed hypothyroid patient? So this question is from Ghaziabad. Dr. Philip, please.
So as per our NICE guidance, we use the dose, weight-based dose. So 1.6 microgram per kilogram for somebody under 65, or if it's somebody's over 65 or has got a cardiac condition, then we start at a lower dose of 50. But otherwise, typically, a well patient is, the NICE guidance is freely available just online. We use 1.6. This is a change in practice. This is over the last couple of years. Before, I would have gone for 50, but now I go for the full dose, 1.6 microgram per kilogram, unless there's any age concerns or cardiac concerns.
That's a correct point. And it's always, if the patient has got other issues like cardiac problem, we should be a little careful. Otherwise, we'll go for full dose. The second question is, how does lithium is affecting the thyroid disorders? Question is from Bhopal. Lithium and thyroid. That's a question.
So lithium can cause hypothyroidism. It can also cause hyperthyroidism as well. So we would manage the situation as per the thyroid function. They'd be monitored, and if it's hypothyroid, we would treat as you would. But quite often it can also cause hyperthyroidism. Interestingly, it's also been used for protecting the sort of hyperthyroid patients. If you can't give anything else, we use lithium to prepare for radioiodine treatment. So lithium is actually quite an interesting drug for thyroid.
I think, sir, next question is a little away from your topic for the time being. See, a case of hyperthyroidism on PTU, and follow-up shows a normal levels of T3 and T4, but TSH level keeps on the suppressed level. So the question is, should we continue the same dose or to increase? It's a very good question. I think it's very common, Dr. Philip, it's very common to see this type of scenario, and people are doing very funny management also. I think clearly you should give the messages for this.
So the TSH can lag behind for a few weeks and even months after T3 and T4 normalization. So if the T3 and T4 have normalized, I would not automatically do anything. I would just continue to manage the same dose and bring it down with that, because the TSH can lag behind for a few weeks and months. So don't make a dose increase based on that. Stick with the same dose, just monitor thyroid functions every 2 to 3 months.
That's a very, very important statement. See, we should rely on the clinical profiles and not to the TSH levels. Next question, what is the prognosis of autoimmune thyroid disease? That's another question now.
So the prognosis of autoimmune thyroid disease, if you just got thyroid antibodies, we know that there's a statistically a 2 to 2.5% risk of hypothyroidism per year. So somebody who's got strongly positive thyroid antibodies, over the next 10 years, 25% chance of becoming hypothyroid. Besides that, that is sort of just basically monitoring for hypothyroidism, which may come in that. Sometimes some people can have a destructive phase. The antibodies can destroy the thyroid and you can have a hyperthyroidism, but that usually lasts only 2 or 3 months and then settles down to hypothyroidism afterwards.
So to the point, he answered the question. I think another question, if the patient is on thyroxine and follow-up TSH is between 5 to 10, is it necessary to increase the, what is it, I think Canada, something like that, dosage of the molecule, the thyroxine? And part of the question is the dietary modification during treatment for hypothyroidism. There are 2 parts for the question.
So I think the answer is we would aim to get the TSH into the normal range. So if they have been on that dose for at least, say, 2 months, I would definitely put up the thyroxine dose to try and get the TSH into the normal range. And quite often we actually try and get the TSH, the patient is a young patient, TSH into the lower half of the normal range because you know that you're treating them adequately. So yes, I would increase the dose for that. In terms of diet during therapy, there's no specific dietary requirements or needs other than the fact that you want to make sure you separate your thyroxine tablet from any medications or tablets with that. So we don't usually make any specific dietary recommendation.
Very interesting question. Next question is very, very interesting, I think. Does subclinical hypothyroidism requires variable dosing pattern as per seasonal variation? Dr. Konar from Kolkata.
I'm not aware of any reason for that. Maybe one of the audience or one of the expert panel might be able to comment on that, but I would not be doing anything different on a seasonal basis for here.
As far as my knowledge goes, there is no difference at all. Anyway, next question is partly related to that. TSH is a monitoring tool for hypothyroidism. Is there any standard protocol yet regarding the type of assay, timing? Is it fasting sample or fat sample?
So obviously there are issues about assays because different assays might come up with different things. And also on the point of assays, there are a few things which interfere with the assays, particularly biotin is something which has got a recent media and press about with it. But we usually we don't ask for a fasting sample. We just when the patient comes to the clinic, we do that. We know that there is a slight reduction based on the timing of the thyroxine, but in reality, I don't think it's not enough to make it inconvenient for the patient. So we just measure at that. We know that, as I say, just as I showed you in my example, when you give a dose, the TSH goes down slightly in a few hours and the free T4 goes up slightly. But because it's so common, we don't factor that in. We just do it when the patient arrives.
Next question is this one, even though basic question, it's a very important question by one Muhammad Mazarullah. See, what are the causes of hypothyroidism? How to explain the patient nowadays? The hypothyroid is very common. Next question is, what is the proper time to take thyroxine tablet?
So the proper time to take thyroxine tablet is easy. It's first thing in the morning. It's 1 hour from any other, half an hour to 1 hour from any other medications or meals. If the patient can't manage that, you can take it last thing at night, 2 hours from your last evening meal. So these are, the timing is clear. And as I say, either first thing in the morning or last thing at night. Causes of hypothyroidism. In UK, it is by far autoimmune hypothyroidism. We would say it's pretty common. And as you grow older, it's about 5% of patients that will have at least subclinical hypothyroidism. It can go up to even 10% once you're in your 70s and 80s. I think in India and other places, some areas, particularly Himalayans and things like that, iodine deficiency is still there, but I suspect it. I don't know. The folk in the panel may comment whether iodine deficiency is still a factor in hypothyroidism in India. Would you say that still?
No, I think the commonest cause, at least in this part of India, definitely autoimmune. It's not the iodine deficiency. We can ask the opinion of Bombay group, Dr. Shaila. Your opinion from Mumbai and Arpan sir from Bangalore. Opinion. The most common cause of hypothyroidism in your place.
Autoimmune.
Yeah.
So unless put otherwise, it has to be autoimmune because there is nothing else left.
I think that is the commonest cause in India. There is no doubt about that. I think sir has covered most of the questions also, and very clearly he conveyed the messages I think it's the time to wind up the first session. I'll close the first session and we'll go for the second topic. I think Arpan sir is giving the talk or Shaila?
I'm there, Jabbar.
Yeah, okay. Dr. Shaila, I don't want to introduce Dr. Shaila in detail because she's a very non-figure and she's a junior. She was junior to me in Bombay University. Very efficient, very active, very cordial personality. Now she's working in 2 or 3 hospitals in Mumbai, Saifi Hospital, Wakad, and Prince Ali Khan Hospital. She's a very active person in the organization activities like, Diabetes India. And even though she did not mention anything about the Endocrine Society of India, I think she's an active executive member of Endocrine Society of India also. I think she's going to discuss about the hypothyroidism or thyroid disease in relation to pregnancy. I think that's a very, very important topic that I've chosen for today's discussion. I don't want to waste my time. Over to Dr. Shaila for the presentation. Over to Dr. Shaila, please.
Thanks, Jabbar. Thanks for those very, very kind words. I have such pleasant memories of you as my senior. So really looking forward to this meeting. Thanks to the organizers for inviting me and making me a part of this lovely symposium. I really enjoyed the previous lecture. And I hope I can live up to the high standards already set over here. Coming to, as Jabbar, just said, hypothyroidism in pregnancy, I think at this point of time is assuming increasing relevance and increasing importance. And why am I saying that? When you look in a clinical practice, in a very busy clinical practice, which all of us, we all are busy clinicians, 2 very common scenarios that you see in clinical practice is A, when your patient already is hypothyroid, he's been diagnosed with hypothyroid, may or may not be euthyroid at this point of time. That's something we'll discuss, I'm sure, as we go along. But this patient is euthyroid on Eltroxin replacement already. A, this situation could be here, this patient wishes to become pregnant. Or B, this patient tells you that, yes, I am planning pregnancy, ma'am or sir, and what advice would you give me? A very, very common scenario at this point of time, which we are seeing because we all know that the incidence of autoimmune hypothyroidism has increased. B, there could be a situation, the second most common situation that we could face in clinical practice is, we know a lot of our patients are at this point of time undergoing preconception counseling, undergoing preconception evaluation regarding their fitness to get pregnant. We have a huge population over there who's undergoing evaluation, health checkups, where they come to you with a thyroid report, which is showing, for example, maybe a TSH of 5, a TSH of maybe even 4.5, and is sent to you from the gynec saying that this patient is having early pregnancy. What do we do? A lot of our patients, unfortunately, also because this mindset that thyroxine can be actually dangerous for the mother, or any medicine, allopathy medicine per se can be dangerous, also sometimes come to you stopping the medication. So you find all kinds of different scenarios with different mindsets when you're dealing with pregnancy and hypothyroidism. Some of these different mindsets we will try to talk as we go along. The prototype of this patient, I would love to know the answers from the audience as we go along. Do we tell these patients, when a patient comes to you, say at this point of time, a patient is sitting across you and tells you, Dr. Saab, I want to get pregnant. What advice would you give me? Would you tell this patient that, yes, you increase the dose of Eltroxin by 30 to 50% as soon as your UPT is positive? Or do you make it more simple and tell them increase the dose by 2 tablets per week as soon as the pregnancy is confirmed? Or would you be very cautious and say, no, check TFT as soon as pregnancy is confirmed and then increase the dose if required? Or are you going to say, okay, if you're planning pregnancy, I am going to increase your dose before pregnancy? These are some of the questions that we will try to answer as we go along. So when you are talking about the prevalence of hypothyroidism in pregnancy, you would realize the prevalence is 2% in iodine sufficient areas. Hypothyroidism per se is 2%, but subclinical hypothyroidism again is around 2 to 3%. And actually subclinical hypothyroidism at this point of time is more common than overt hypothyroidism. We also see isolated hypothyroxanemia, which is a normal TSH with a FT4 below the 2.5 percentile, which again is seen in around 2% of pregnancies. So this is the kind of incidence that we are seeing at this point of time in our patients. We need to understand in pregnancy, 25% of the patients with subclinical hypothyroidism will continue to have a persistent TSH elevation even after delivery. A very, very big gray zone, especially when patients are having now with late pregnancies, precious pregnancies, pregnancies conceived with some amount of help or some amount of difficulty, are the situations of euthyroid patients with positive thyroid antibodies. This is seen in 10% of pregnant women, and a fifth of these patients will develop hypothyroidism during the course of pregnancies. The obstetric consequences, mind you, remain controversial. It's not very clear, data is still not very clear, but there has been seen an increased risk of pregnancy loss in meta-analysis of spontaneous and assisted pregnancies. And believe me, I had a patient who came to me around 2 weeks back, who actually came to me, who Googled this entire issue, came to me with the meta-analysis saying that, madam, no, I think I should be treated, though this is my first pregnancy, but my antibodies are positive, and I think it is very, very important that you treat me. So we are seeing these kind of situations in the educated people who are coming to us, and it is very, very important that when you are deciding for or against treatment, that you make an informed decision with the patient. It is at this point of time becomes mandatory. What are the possible mechanisms? Why are we seeing pregnancy loss in this situation? Whether there is actually an intrinsic thyroid hormone deficiency, whether there is diffuse autoimmunity, or whether there's an impaired thyroid response to HCG, are some of the mechanisms which have been postulated to try to explain as to why are we seeing this kind of pregnancy loss. When a meta-analysis was done of 18 cohort studies, these were around almost 4,000 patients, what was seen? That pregnant women with subclinical hypothyroidism were 2 times more likely to have pregnancy loss, 2.6-fold more likely to suffer a neonatal death, and mind you, also high risk for placental abruption and premature rupture of membranes. Then why are we still having these gray zones? Why is there no clear-cut guideline that you screen all pregnant ladies? At this point of time, even now, the universal thyroid screening is recommended in Spain, China, Poland, whereas UK and US again says a case-finding approach targeted at women at high risk of thyroid dysfunction. And what is recommended closer to home? Closer to home, the Indian guidelines tell you that you screen high-risk patients, A, if they're residing in an area of moderate to severe iodine deficiency, if they are obese, if they have a history of prior thyroid dysfunction or a prior thyroid surgery, if they have symptoms again, we all know in clinical practice can be plus or minus, but if they have symptoms or presence of goiter, again, you would screen them. If there's a history of a thyroid dysfunction in the first degree relative, they again become high risk patients. A history of mental retardation in the family or in a previous birth again becomes a reason to screen them. Any kind of autoimmune disease, be it type 1 diabetes, SLE, rheumatoid arthritis, Addison, celiac, etc., would also be a reason for screening our patients. We all know patients with recurrent miscarriages, with preterm deliveries, with any kind of intrauterine death, preeclampsia, eclampsia, abruptio placenta, any kind of BOH, basically, we do screen our patients as a routine. Infertility again becomes a reason for you to screen, and we have already been speaking about lithium and amiodarone or administration of iodinated radiological contrast, which would become a reason for screening. When a universal thyroid screening program actually fulfills most of the criteria for a beneficial and cost-effective screening program, and it does hold promise for improving fetal and maternal outcomes, still, because there are certain areas of uncertainty as to what is the significance of borderline biochemical abnormalities and whether actually these abnormalities are going to improve outcomes. So there is no consensus at this point of time, and we cannot have consensus unless we have few more trials which actually recruit women pre-conception or as early as possible in pregnancy. So what are the challenges? Why is the thyroid different in pregnancy? What is different about the thyroid in pregnancy compared to a non-pregnant lady? And how are you going to interpret those TFTs that you see? Your patient comes to you with a TFT report, and then it is your job as a clinician to understand, is this significant? Is this clinically relevant? Will I treat? Will I not treat? Will I just observe? Will I monitor? So which trimester report is this? So many unanswered questions when you're actually looking at the apparently very, very simple TFT of that lady who is pregnant. We all know that there are certain changes which occur during pregnancy. There are certain adaptations which occur because you need to maintain the fetal thyroid hormone delivery in the face of increased requirements. And what are some of these changes which occur during pregnancy? We all know there's increased TBG production. And we all know because of the sharing of the alpha subunit between the HCG and the TSH, there is stimulation of the TSH receptor by HCG. And of course, there's increased peripheral thyroid hormone metabolism and also increased iodine excretion by the kidneys. These are some of the explanations. I won't go into great details of this, but yes, these are some of the changes which occur. And also because pregnancy is a state of increased GFR, there's a magnified demand on the thyroid to secrete T4 because there's also increased excretion of T4. So what do all the organizations tell us? What do the different associations that we follow tell us? A very, very important point that they bring across, which we still have not been able to achieve, is that each center, mind you, should establish its own trimester-specific reference intervals for thyroid profile so that you can make timely and appropriate detection of thyroid abnormalities and then make interventions accordingly so that you can prevent your fetal-maternal complications. We all know there is limited data. And when there is no established reference intervals, there is always going to be an increased chance that you're going to misinterpret the normal changes as pathological. Or maybe you will actually miss important events due to pathology, assuming that it is normal. So you can actually go on either side of the fence. You may interpret a normal as being abnormal, or you may interpret a normal as being part of the physiology of pregnancy. TSH at this point of time is still the primary test for evaluating thyroid status, but you sometimes cannot rely solely on TSH because we know that TSH is linearly suppressed by HCG. And what are the reference ranges which are accepted at this point of time? What are the trimester-specific reference ranges which are accepted? The trimester-specific reference ranges which are accepted in the first trimester, it is 0.1 to 2.5 MIU per L. Subsequently, it goes to 0.2 to 3 in the second trimester and 0.3 to 3 in the third trimester, because we know as the HCG goes down, the TSH is going to go up. Again, if you look at center-wise differences, these are the kind of differences. Even in our subcontinent, there are differences between the ranges in Pakistan and India. And that is the reason it is very important that we have center-wise differences to understand that, yes, these are the kind of ranges you are looking at in your population in the first trimester and second trimester, especially the first trimester, where we know organogenesis is going to be dependent on the thyroid hormone. So whom do we treat? When do we treat? What do we do? And how do we go about it? At present, the guidelines tell you, yes, definitely treat women with a TSH more than 10. So I think that's a closed book. More than 10, I don't think there is any confusion. We treat. But if a patient has a TSH of between 4 to 10, then a patient with antibody positive, those are the patients who are believed to have intrinsic thyroid disease and will progress to thyroid failure. And those are the patients that we should be treating. How would you treat them? We all know levothyroxine is safe, extensive data out there, but definitely we do not want desiccated thyroid extract or liothyronine, the so-called, some of the so-called alternative branch thyroid medications which are available. I always request my patients do not take them during pregnancy. At least during pregnancy, I do not want you to consume something I'm not very sure about. And those studies, in the CAT study, it showed, though this CAT study actually, to bring a point into perspective, had a fixed dose of levothyroxine. So yes, a high proportion of overtreatment was also seen from almost 20 to 40% and 10% during pregnancy. And we need to keep in mind that you cannot use levothyroxine inappropriately also. You need to be in range. You need to be at target. You are not looking at overtreatment also. So what kind of doses are you going to talk in terms of? As Dr. Abraham was talking about, we are going to talk in terms, if your TSH is more than 10, it is going to be 1.7 to 2.5 mcg per kg daily. And if it is 5 to 10, it is going to be 1 to 1.7, or up to upper limit of normal to 5 would be around 1 to 1.5. If you want to remember it a little more simply, I would say it would be, say, 50, 75, and 100. that makes life a little simpler in routine clinical practice. The gray zone. Till here, very clear, no issues whatsoever. I'm pretty sorted out. Now, what do I do about these patients with subclinical hypothyroidism? Do I treat? Do I not treat? My gynec is very adamant. Shaila, the TSH is 3.5. Why aren't you doing something about it? This patient should be treated. What do the guidelines tell us? Overthyroid disease, as I said, yes. Antibody positive women with subclinical hypothyroidism, again, the guidelines say that yes, most recommend treatment. Euthyroid autoimmune women or women with subclinical hypothyroidism and negative antibodies, again, the guidelines are a little gray out there, not very clear, weak evidence. And that's where your role as a clinician comes in. That's where you as a clinician will decide whether you want to treat. You would take into account, most probably what I would take into account is a patient's medical history, whether this patient is having a bad obstetric history, what kind of levels are you seeing, and what kind of, whether you're seeing a goiter, what is this a very precious pregnancy. I think all those things would be taken into account when you finally make a clinical decision after discussing with your patient the risks and benefits, and then decide whether to treat or not to treat. And why is this? Because there's no RCT telling us whether LT4 therapy improves outcome for infertile women with SCH not undergoing assistive reproductive technique. This is before conception. Also, LT4 therapy to aid conception in thyroid autoantibody negative infertile women with SCH who are not undergoing ARTs. There is no RCT. So this, you come back a step and you're talking about before conception. The AT has again given you a very weak recommendation that you may consider in this setting, given that it may prevent progression to overt hypothyroidism once pregnancy is achieved. Again, as I said, make individual decisions, make decisions keeping your patient in mind. In patients undergoing ART, at this point of time, we have evidence that LT4 definitely improves pregnancy and miscarriage rates. So the only area where it is accepted that yes, before conception, SCH, a patient you can, and also in patients with euthyroid antibody positive, in patients who are undergoing ART, you are justified in using L-troxin therapy. The other areas, you will make individual decisions. So as of now, you would use it in your pregnant patients, positive for antibodies when the TSH is above 4. You may use it in patients positive for antibodies if the TSH is more than 2.5, a weak recommendation. Antibody negative when TSH is between 4 to 10, again a weak recommendation. But as I said, in clinical practice, you may face a lot of situations where if your patient's TSH is more than 4 and even antibodies are negative, you may decide to go in and treat your patient, keeping in mind all the other parameters. These are some of the clinical evidence which we have out there, which shows that the beneficial effect was seen in patients with LT4 treatment when they were antibody positive with a TSH of more than 4. And again, another study which shows that no beneficial effect was seen of LT4 in reducing preterm delivery in SCH antibody negative women with a TSH of 2.5 to 10. But when this was further a subgroup analysis was done, it was shown that LT4 could decrease this complication if you use the newly recommended TSH. So as I said, a lot of evidence out there, but you would make your individual decisions. Now, if a patient, coming back to the case we were talking about, if a patient is on thyroid medication before conception, we all know this patient is going to require higher dose of LT4 during pregnancy. And the current guidelines say that LT4 treated hypothyroid patients who just get pregnant, our advice to them should be that you need to increase your LT4 dose by 25 to 30%, even without measuring the TSH once you find you are pregnant. And of course, then notify your HCP. Some studies have shown, the study by Verga et al. Showed that actually this increase may not be sufficient. You may need to increase the LT4 dose much more than that. But as of now, the guidelines say you increase it by 25 to 30%, and then you could possibly do a test and again make individual decisions. Could the dose actually be increased depending on what is the etiology of hypothyroidism? In autoimmune hypothyroidism, it was seen a dosage of approximately 16% was good enough. With malignancies, a higher dosage increase was required, almost 20%. But if the patient was athyrotic, they would require much higher dose of almost 50%. So again, the bottom line is individualization, individualization, individualization. Please also, when we are talking about guidelines, we always need to understand that finally guidelines are adapted according to individual situations. There was a question just to Dr. Abraham, asking him whether women who were diagnosed with, though this was in non-pregnant situation, patients who were diagnosed with SCA during pregnancy, there is no recommendation regarding the starting dose, but you may start with a low dose of 50 mics and then titrate accordingly, which appears to be a reasonable way forward, because there is no evidence regarding what kind of dose you would absolutely use. So when you are monitoring these patients, what would be your goals? We have already spoken about trimester-specific goals. You need to monitor your patients every 4 weeks during the first trimester, which is very, very important. And definitely at least once near 30 weeks. These are the ATA recommendations. The Endocrine Society says monitor your patients every 4 to 6 weeks throughout pregnancy. And again, keep the TSH within trimester-specific goals. Following delivery, you reduce the patient to the patient's preconception dose and monitor the patient 6 weeks postpartum. Sometimes if your patient is unable to come 6 weeks postpartum, which often happens with my patients in follow-up, we at least tell them to do their thyroid function test and send it across to us with whichever way they can. For women who were initiated during pregnancy, this is another very important area. The patient was initiated medication during pregnancy, patient has delivered. In these patients, if the doses was less than 50 to keep the patient euthyroid throughout pregnancy, you can potentially also stop the medication. The decision to discontinue, mind you, should be made in conjunction with the patient. And very, very important, if you decide to discontinue, please evaluate the TSH again after 6 weeks. Again, you need to monitor your patients. You cannot discontinue and not afford to monitor your patients. So is there some algorithm which I could sort of share where we could just understand in a very, very simplistic way all that I tried to put across over the past few minutes? This is what you would do. This is how you would approach your patient with an abnormal TSH level in pregnancy. You have a pregnant woman who is at a high risk for thyroid dysfunction. This patient has come to you. This patient has a goiter, maybe having antibodies, maybe having a bad obstetric history, maybe having a family history, maybe obese, maybe diabetic, maybe having some kind of autoimmune disorder. And you decide that, yes, we need to investigate this patient, we need to evaluate this patient, and you measure this patient's TSH. Now, this patient's TSH could be anywhere in the spectrum, in the sense that this patient's TSH, if this patient's TSH is more than 10, or this patient has a low FT4, you would check the patient's antibody status, confirm autoimmunity, and commence treatment. Okay. Now, if this patient's TSH is between 2.5 to 10, again, you would check the antibody status. Now, if this antibody status is negative, but the patient's TSH is more than or equal to 4, you could still consider treatment. Again, an individual decision. If this patient's antibodies are positive, mind you, and this patient's TSH is more than 4, I think it's pretty okay to treat. You would go in and treat the patient. Now, the gray zone between 2.5 to 4, antibodies positive, you do still have recommendation that you can consider treatment. You can think in terms of treating this patient depending on individual discretion. What happens if the patient's TSH is lower than reference range but still detectable? We already spoke about the fact that in the first trimester, your patient's TSH can go low because the HCG cross-reacts with the TSH receptor because of the alpha subunit. You would repeat the TSH in 4 weeks' time, especially if this patient is coming to you with, for example, with hyperemesis gravidum, where you're worried whether you could actually be dealing with a situation of hyperthyroidism. Repeat the TSH after 4 weeks. If the TSH is still undetectable, yes, then check T3, T4, and of course, check the thyroid receptor antibodies. And then accordingly make decisions about treatment or not deciding to treat the patient. That would be a total different subject by itself. Our area of concern at this point of time are all TSHs which are above 2.5 with or without antibody status, with or without the history, where you would make an individual decision as a clinician as to which patient of yours actually needs therapy and then treat the patient to goal so that you have an absolute morbid-free pregnancy, and you at the end of this pregnancy can have an absolute safe delivery, and your patient does not have any of the associated complications. We all know that thyroid dysfunction in pregnancy is associated with a number of complications, be it premature birth, be it preeclampsia, be it gestational hypertension, be it also some amount of neurocognitive dysfunction. We need to understand that all these issues need to be taken care of, and it is very, very important as a clinician that we keep our patients' thyroid levels within normal limits throughout pregnancies. Thank you very, very much.
Thank you, Dr. Shaila, for the excellent exposition of the topic. I think you asked two questions and you have answered clearly those two questions. Whom to start, when to start, how to start, and dosage. And that's clearly with the evidence-based medicine, which is published in Endocrine Today 2019. It was a very, very beautiful presentation, very, very explanatory statements. Okay. And I don't want to add much, and questions also very less. I don't know why, but we have a question here. Hypothyroidism more than 10 years, TSH is normal and no signs or symptoms. What is your step? That's a question.
Hypothyroidism more than 10 years, TSH is normal.
Normal.
Huh?
Yeah, what is, with no signs and symptom, what next? That is a question.
No, you will just continue thyroid medication in the sense that if you're talking about pregnancy, this patient is planning a pregnancy, then as I said, you would advise the patient at the moment, whenever she gets pregnant, before she connects with you also, and especially in the present situation where with the COVID pandemic, patients are worried about moving out of the house, patients are worried about doing any kind of test, especially pregnant ladies are immunocompromised, they do not want to expose themselves to any kind of infection. Till they do the test, please ask them to increase their thyroid dosage by 25 to 30%. That is standard guideline, very, very safe. The other way practically you can tell them is increase 2 tablets per week. That is a practical way of increasing the medication and a simpler way of telling them how to increase the medication. But that is mandatory.
I think the messages are very, very clear. Okay, whatever be the duration, you should maintain your TSH level, especially in pregnancy. You should be very, very careful because you are dealing with the two issues, okay, maternal as well as fetal. I think the chapter is very clear. So there are no more questions. Once again, I thank Dr. Shaila for the excellent discussion. Thank you very much, Dr. Shaila.
Thank you.
And we'll go for the last session. The sessions by one of the senior most endocrinologists of our country, Dr. Arpan Bhattacharya. He is a very, very senior person. He's working as a senior consultant in Manipal hospitals, and he's also a lot of teaching experience in Davangere JJ Medical College, and is instrumental having a very dedicated setup also in Bangalore, and he's having lot of publications in the index journals, and we'll be discussing the topic. Topic is very, very relevant. Okay, we have a lot of diabetes patients, lot of thyroid patients. So we have twin epidemic now. I think Dr. Arpan is going to link between these two and is going to discuss about the consequences, issues, merits of treatment, all those things. And with a small introduction, I invite Dr. Arpan for the session. Over to Dr. Arpan.
Thank you very much, Dr. Jabbar. Good evening, everybody. Can I have the share screen option? I exactly don't know what is the full definition of the senior, but when somebody tells senior, I feel a bit uncomfortable. That means I need to do a better job. But by any chance, if anybody is there like a diehard fan of Manchester United, we are leading at this point by 2-1, and I will keep you updated. I'm sure the margin will get better as my talk progresses. So that's a little bit of a disclosure we need to tell these days. For medical legal reason, I did participate in some clinical trials in the thyroid arena. But today's meeting, I'm a contracted speaker at the MacLeods. I'm a member of some ad board of some pharmaceutical companies, but I do not have a share in them. But I take full responsibility of the text of my talk. Next around 20 minutes, I'm going to take you through about this twin challenge. Now, if you go to Google, a simple Google is the thyroid and diabetes. And if you click, then you see less than 0.5 second, you get 75 lakh hits, and they are all scholarly article. And that's some hypothyroidism and diabetes. That's we are going to take. See with the prevalence, 2 studies from the Western world I'm trying to quote here on Colorado study, on ENHANCE 3 study. Diabetes with hypothyroidism. We are talking about hypothyroidism. Let us concentrate on that. 9.5% people with diabetes have hypothyroidism, and ENHANCE showed 4.6%. But whatever happened, the fact is that 3.5 times increase of incidence of autoimmune thyroiditis if the GAD positive, that is type 1 diabetes, and also positive antibody in the people with the diabetes to the tune of around 38%. Fact remains, the pathophysiology or connection between two, even though there are a lot of propositions that are not very clear, are not very well understood. This is a study from the India which showed that we are a part of this study. This is an observational study from the 6 metro, that 1 in 10 adults in India suffer from hypothyroidism. And adults the age of more than 35 years are at risk of development hypothyroidism. And we know that 1 in every 3 diabetes patient could have undergoing thyroid disorder. Of this, 1/3, they don't know that they have a thyroid condition. And if you can see this percentage and project this to our population, you can understand how huge will be the problem and the challenge of our twin challenge. And there was a campaign some time back in the medical fraternities that diabetes mellitus and hypothyroidism are strange bedfellows or a mutual companions. Now, if you see this now, the left side of the slide, if I put the laser pointer, left side of the slide, you see the poor glycemic control may mimic hyperthyroidism. In terms of fatigue, increased appetite, weight loss, symptoms may be common. But we are talking about hypothyroidism. So diabetic nephropathy, we will come back to this point again, diabetic nephropathy, they mimic myxedema, primary hypothyroidism. Obviously, in the later stages, because the chance of edema, the fatigue, the pallor, the weight gain are quite common. So metabolism-wise, in carbohydrate metabolism, there is increased predisposition of the hypoglycemic episodes. And it is a funny enough state that also insulin sensitivity increases in hypothyroidism, also insulin resistance increases. So it depends on where is the balance is more. So for the lipid metabolism is concerned, hypothyroidism causes deranged lipid profile, unfavorable lipid profile, and that's why the chance of cardiovascular problem is more. So where the protein is concerned, they cause muscle wasting. So it's not only hyperthyroidism, hypothyroidism, even if there is weight gain, there will be muscle wasting and weakness is aggravated. And we all know that primary hypothyroidism or significant primary hypothyroidism is an immunosuppressed state. And this COVID pandemic, this is very, very important. We try to connect with the different pathophysiology like TNF-alpha, interleukin-6. As we are knowing about this corona pandemic going on, that these are very important to diagnose or initiate a treatment on the cytokine storm. So these, both of them, increases actually hypothyroidism. And they contribute to insulin resistance. That's mainly because they reduce the glucose disposal at the level of periphery. That's the insulin resistance. Circulating ghrelin level are inversely related to T3. So if you have hypothyroidism, your T3 is low, your ghrelin level goes up, and that can have impact on the islet cell proliferation and the survival. So thyroid hormones are positively correlated with the insulin resistance. So again, the sensitivity and the resistance, we need to take the balance. Now, observational data or epidemiological data, it tells us that if you think hair fall is aggravated in people with the diabetes if you have a concomitant hypothyroidism, and I believe we need to read as a concomitant untreated or unbalanced hypothyroidism. We know hypothyroidism worsens the pulmonary function and they make us predisposed for sleep apnea syndrome. In the cardiovascular system, although already I have told about that unfavorable dyslipidemia, which increases atherogenicity problem, so thereby making more prone for coronary artery disease. The fatigue and exercise tolerance combination aggravates the physical debility, making this situation difficult. So with this, let's make my cases. As this forum is a case-based discussion, I have 3 cases to share with you. First one, a 35-year-old man comes with weakness and EG fatigability. His BMI is 30, blood sugar 140, 240 with HbA1c of 8.6%. Started on metformin, then added sitagliptin, currently on 100 milligram sitagliptin and 2 gram metformin. 3 months down the line, weight gain is a concern, lethargy persisting, although the blood sugar improved. 116, 148 fasting PP and HbA1c 7.4%. And physical examination noticed a diffuse type grade 1 goiter. Thyroid function test, normal free T4 with the TSH 9.8. TPO antibody is positive. You started on thyroxine 75 micrograms. At this point, he's on thyroxine 75, sitagliptin 100 milligram, and metformin 2 gram. Another 3 months down the line, there's no specific complaint, but look at the blood sugar. With the normalization of the TSH, fasting blood glucose 98, postprandial 132, HbA1c 6.8. Very pleasant surprise that HbA1c in 6 months came from 8.6% to 6.8%, which is a very good response. So this was on optimum dose of oral anti-diabetic regimen. Now, the reason I'm showing you the case is that for 3 things. First one, it's a virtual meeting, so I really can't ask a question, but I'm just trying to see how you feel and you can make up in your mind. Should the physician in charge order a TSH at the first counter? Yes or no? Does it mean that every people with a type 2 diabetes, when they are diagnosed or we are encountered, we should see a thyroid function test is done, and we should, if it is not done, we do it? Probably yes, given the fact that chance of hypothyroidism is much more common in the people with the type 2 diabetes. So one of the reasons can be these are the people with the diabetes are more exposed to medical fraternity. Obviously, they are being diagnosed more often. So it may be possible that general population, they're not much different, but when we are taking a selective population, it is. But the fact remains, the answer should be yes. And the second one, does thyroid hormone affect the glycemic control? Is it yes or no? I'm sure you got all that already on the hint. The answer will be yes. And third one is a bit more complicated. That's which anti-hyperglycemic agent affect the thyroid? Is it metformin? Is it thiazolidinine? Is it sulfonylurea or GLP-1 receptor analog or all of the above? Actually, answer is metformin. And there are a lot of data that are available that both at the level of central, that is hypothalamus pituitary area, and the peripheral, that is liver and the peripheral tissue, metformin has a lot of things to do with the thyroid function. So as you see the cartoon on the right side, hypothalamus pituitary, then thyroid, circulation, tissue, and the renal. And we all know the metformin basically works via AMPK mechanism, which is a suppression of hepatic gluconeogenesis. Interestingly, I'll come to another study in the same point. In the bottom part of this slide, you see 2010 publication that 66 patients with a benign thyroid nodule given metformin, they showed a significant reduction in most of the people. And that's, we believe, is because of the central effect of the metformin, which is reduction of the TSH. And we know that TSH is a growth-promoting effect on the thyroid. So if you reduce the TSH, then your thyroid nodule size can come down, or the goiter grades can come down. And that may be a potential area where a benign enlargement of thyroid, which we do not have an established treatment till now, metformin can happen. And these are some of the studies. There are plenty of studies that are available in the literature that if you give 1 year of metformin, given 1 gram per day, a significant reduction of the TSH. People who are on treated hypothyroid, people who are on untreated hypothyroid, and no significant change of free T4 is observed though. And there are 30% shrinkage of the initial nodule size of the metformin, when some of the studies, it can go up to 55%, which has been calculated by the ultrasound. So metformin reduces the thyrotropin level, and this is what the message we need to take home. So effect of metformin on TSH suppression is confirmed. So clinical situation for you and me, two places is important. One is a benign thyroid nodule or a euthyroid diffuse goiter. Second is a thyroid cancer. So we need to explore whether metformin has a role in these two areas with reducing the TSH without causing any biochemical hyperthyroxinemia or a clinical hyperthyroidism. But you need to remember the flip side. The flip side is there will be a complexity in monitoring thyroid function when person is on metformin. People with the diabetes on the metformin, which is pretty common, as you explained about the prevalence. And there will be a problem in monitoring the thyroid function if the people are on metformin level. You need to keep in mind. But there's nothing that to be a bit serious, but it's important when you adjust the dose of both of them. With this, let me move to the second case, the case capsule 2 in my diary. Is that 59-year-old man, banker by profession, the 12-year diabetes with a strong family history of premature coronary artery disease. On metformin 1 gram, glimepiride 3 milligram, and insulin glargine 20 unit. Now, he had lost around 3 months. He had noticed the frothing of the kidney, frothing of the urine. Also, lethargy, little forgetfulness, clinical examination, little pedilipidema, also complained of a bit of constipation. BMI near 30, BP acceptable, delayed tendon jerk reflex, GFR 42, urine microalbumin 30, but thyroid function showed TSH 7.6, free T4 1.02. This is nanogram per DL, the normal range, lower range of the normal range with a TSH raise. So this will give a definition of subclinical hypothyroidism. Now, what is the relation of thyroid function with the complications of diabetes? Okay, complications of diabetes. For example, this person is a diabetic kidney disease. GFR is low, microalbumin positive, duration diabetes 20 years. Now we have a subclinical hypothyroidism, new diagnosis. What my question is that, is subclinical hypothyroidism anything to do with nephropathy? Do we have any information in the literature? Actually, indeed we have. There is an increased risk of nephropathy in type 2 diabetes, subclinical hypothyroidism, and this gets better if we treat them. Probable pathophysiologic mechanism is decrease in cardiac output, increase in peripheral vascular resistance, resulting in renal blood flow is decreased, the GFR gets worsened. And treating hypothyroidism improves the renal function. So diabetes people with subclinical hypothyroidism also should have more significant retinopathy and neuropathy in the literature. But again, you need to think of the same thing. Because these are the people with a complicated diabetes, they are coming to the medical fraternity again and again, whether we are detecting them or not. But the good news is that if you treat a small dose of a thyroxine, we have evidence there is chance of improvement. And lastly, a very important, I'm going to show you a case also, the chance of hypoglycemic events is more in people with undetected hypothyroidism. So subclinical hypothyroidism, in diabetes people, prevalence around less than around 10%, up to 10%. I'll show you the greater prevalence of diabetic nephropathy, cardiovascular event, and also a neuropathy. And this is what is important. We all speak quite loudly about the effect of unfavorable dyslipidemia in subclinical hypothyroidism. We know, and that is one of the indications that we should be considering treating subclinical hypothyroidism very clearly. And this brings to my case capsule 3. This gentleman is 73 years, a diabetes for 20 years, and recently documented to have a recurrent hypoglycemia. And quite a number of times, he has self-checked the blood sugar to be 70 milligram or low, and once he recorded an IV glucose and blood sugar recorded as 39 milligram. His insulin dose slowly reduced, currently on 8 unit, but he was maintaining a good control last 4 or 5 years. BMI is good at 22, blood pressure is normal, heart rate little lower side is the 62 beat per minute and regular. HbA1c is 7%, reflecting good control at the age of 73. Normal renal parameter. Anybody with a hypoglycemic episodes of the type 2 diabetes, you must check the renal function because that is one very important clinical pointer. And the thyroid function test was done. That showed an abnormality. PT4.8, very lower range of the normal, or a little bit lower than the normal. TSH 8.8. TBU antibodies, however, was negative. And diagnosis of subclinical hypothyroidism made, and he was started on thyroxine therapy. And this is what we believe the mechanism of action. And significant hypothyroidism will decrease the intestinal glucose absorption, and also by decreasing the hepatic gluconeogenesis and glycogenolysis, the hepatic glucose output will be less, so that hypoglycemic chance will be a bit more. But at the same time, because of decreased activity of the GLUT4, their glucose disposal at the tissue level, that is insulin resistance, also decrease. So it's a balance between insulin sensitivity and insulin resistance, which in this condition goes in favor of increased insulin sensitivity, thereby making you more prone for hypoglycemia. So hypothyroidism predisposed to hypoglycemia. A person with a recurrent hypoglycemia detected by subclinical hypothyroidism will benefit from a low dose of thyroxine therapy. And this particular cartoon showed about hepatic hypothyroid. One side, hepatic hypothyroid causing hypoglycemia. Other side, hepatic hyperthyroidism, making a prone for destabilization of the blood glucose. So other thing which I would like to see what's Prakash's opinion. We have actually published some cases, and there are some recommendations, some bodies is there. If you diagnosed to have a severe primary hypothyroidism, where the TSH is very high and FTP very low, and once you start initially a full dose of thyroxine, they may go to an adrenal crisis. They may have a subclinical hypoadrenal state, and also even if their adrenal status is normal, if you have a severe primary hypothyroidism, you may have a transient impairment of the HPA axis, and that's probably a good area for the clinician that to cover them for around 4 to 6 weeks with a hydrocortisone supplement to prevent the undetected adrenocortical crisis. And particularly, this is important for our country because each and everybody, it is very difficult for us. Even we are practicing in the cities, it's very difficult to test for adrenal reserve. And this is something like this has been projected by Dr. Sheila as well. So we just pick up the hypothyroid area. So baseline evaluation of TSH, FTP4, thyroid dysfunction, subclinical hypothyroidism is a 5 to 10. You consider therapy, think of cardiovascular risk factor, goiter, rising TSH, and more than 10 is certainly an indication to start on treatment. But there are certain things which really should make us think in future ahead about this field. What are the mechanism of action? This slide shows a difficult mechanism of action, which certainly I do not understand much. But the fact remains, most of these effects we are talking about central peripheral is via the AMPK, and of which a crucial link is called MAFA. So MAFA is a glucose-regulated and pancreatic beta cell specific transcriptional activator for the insulin gene. And that possibly can give us a link between a thyroid cancer and diabetes. Although we are talking about twin challenge over hypothyroidism, and here we are trying to introduce a problem with people with a people with a type 2 diabetes, what way they can be more prone actually for thyroid development of thyroid cancer. It's all related to the hyperinsulinemia, the TSH, the other all inflammatory markers, and certainly, as always, everywhere, so vitamin D usually come, GLUT4 receptor, and this. These are our future thing. A lot of work is going on. We need to wait for some results which come. So I heard somewhere this Enrico Fermi has told, before I came to this course, I was confused. Now, after attending, I'm still confused, but on a higher level. I hope I have not made you confused it. So this is my summary slide. Hypothyroidism, both overt and subclinical, are frequently encountered in patients with diabetes mellitus. type 2 diabetes patients with hypothyroidism are increased risk for complications. We have shown you nephropathy, retinopathy, neuropathy, although I didn't have a slide of neuropathy. There are data available that neuropathy gets a bit better. All diabetes patients should be screened at baseline for thyroid dysfunction. Now, at this point, a more or less recommendation is that people with the type 1 diabetes, they should be checked once in a year for thyroid dysfunction because of autoimmune pathology chances more. And people of type 2 diabetes, certainly we should be checking at diagnosis and then depending on the clinical state and the clinician's decision. Undiagnosed and untreated hypothyroidism may result in difficulty in achieving euglycemic state. That's what we have showed in the case also. And use of levothyroxine to treat subclinical hypothyroidism with the TSH more than 4.5 might prevent later complication of the diabetes. So metformin TSH, innovative therapy for thyroid polythyroid disease. For food for thought, 2 situations I have mentioned. One is a thyroid nodule or euthyroid diffuse goiter. Second is a thyroid malignancy, where after operation radiotherapy, we try to get a suppressive dose. Thank you very much for your patient hearing.
Oh, very good presentation, Dr. Arpanji. It was a very nice and lucid presentation. I think he has conveyed the messages very, very clearly. Okay, the prevalence of hypothyroidism and diabetes mellitus, the role of interaction between metformin and TSH, and then the role of metformin for thyroid nodule. It's a very interesting point. I think messages are very clear. I will start the question. See, probably Arpanji, when I was a student, we used to give thyroxine suppressive treatment for the management of nodular goiter. Okay. What do you think? Do you think some metformin will be one of the very, very promising tricks for treating or using for thyroid nodule suppressing treatment? What do you think?
Yeah, this is actually very interesting. As I'm showing you some slides, there are small data available that if you give a metformin, it's around 1 gram dose, they have documented the reduction of the thyroid size. And this is really an exciting area because we do not have any established treatment for a benign goiter because people are concerned about the size in front of the neck. So they want to reduce the size. And obviously, if it is a benign and is not causing any pressure effect, putting them under the knife is not the right option. So we tried initially with the thyroxine. For some people it worked, but the problem is that we develop actually a hyperthyroidism, subclinical hyperthyroidism, and which has its own consequences on the heart and the bone. So, but metformin can be an exciting thing, but I think we need a lot more information. But as always in endocrinology, getting a randomized control trial is very, very difficult because we need a lot of time, lot of number of people to do the proper statistics. So we'll have to be seeing a bit of more of observational data, but in clinical practice, if you find somebody with a diffuse goiter and impaired glucose tolerance, you have a licensed indication use of metformin, and obviously we can start and see whether the improvement happens or not.
What is opinion of Dr. Prakash? What do you think? The metformin, and because Resanio paper shows that 30% reduction in the size of thyroid nodule with metformin. It seems to be a very encouraging one. Seems to be a very interesting one. What is Dr. Prakash's opinion in this context?
Yeah, I mean, obviously, this is an interesting possibility, but we need studies. Metformin is a fantastic thing because it seems to be useful for so many things. I mean, we know that cancer diagnosis is there, and even most recently, COVID. Metformin has been shown to be useful in reducing mortality in COVID. So metformin is a fun thing. We should probably put it in our water to get the benefit, because metformin certainly is a cheap drug, has been shown to have lots of benefits. But I think obviously we don't have enough data to recommend that as a treatment option. It's worth knowing it has all these sort of benefits, and it'll be problem is it is so cheap that nobody's going to do any major studies on it as well. That's probably part of the problem as well.
Fact. Now metformin, oncology is one of the favorite drugs is metformin, and SGLT is already taken by cardiologists. So we endocrinologists, we don't have much molecule with us now, right? That's the problem. Now they want to ask you a question. What should be the frequency of testing for thyroid function in type 2 diabetes? That's a Manjusha from Mumbai to Arpanji.
Yeah, that's when we are first time seeing a patient, it is important to see whether thyroid function test is done or not. If it is not done, it is worth repeating, worth checking once. But after that, what will be the frequency is difficult to tell. It depends on the clinician's discretion.
Now, another question, should patient with the increased frequency of hypoglycemia be evaluated for hypothyroidism?
100%. Yes.
That's a correct thing.
Yeah.
And that's, of course, little bit different from your purview, but still, my question is that after late delivery, patient's weight is increasing. What should be the dosage to be given for hypothyroidism?
Well, if weight is increasing, that is not the reason to increase the dose of thyroxine. We are not giving thyroxine as a weight-losing agent. We are trying to stay at a clinical and biochemical euthyroid state. So if the weight increases more, we give a bit more thyroxine. That is not scientific.
I think another question by the same doctor will go to this question. Is it essential to get TSH and T3, T4 level in empty stomach sample? Okay. For the assessment of thyroid function test, is it necessary to go for empty stomach fasting sample?
I think Prakash has already answered. There are some changes there, but that's not clinically relevant. So it is better to do anytime, it will be fine. But when we are doing a clinical trial, obviously we are encouraging the sample to be taken on the fasting level. But the effect is not difference is not clinically significant. So if you do anytime, this is fine. And if patient comes and get the test and reduce, for example, some of the person is coming 250 kilometers away and they do the test, again they wait next day for a fasting test and the report comes, that becomes practically is difficult. So practically it really doesn't matter whether it is a fasting or the fed state.
I think we'll go to another case, very interesting case, doctor. I will take this question to Dr. Prakash. If T4 is high and TSH is normal, what should be the treatment?
If TSH is normal, then you're thinking
TSH is high and TSH is normal, T4 is high. That's right. Euthyroid hyperthyroxine.
So there are three possibilities here. One is compliance issue, if the patient is taking thyroxine. Second thing is whether it's thyroid hormone resistance or, so I'm discussing it in the cases tomorrow. So thyroid hormone resistance, TSHoma, these are the sort of things which comes into the scenario when you have this condition. And then, of course, the more common possibility is it's a problem with the assay, because lots of things affect the TSH assay, antibodies. So sometimes the first thing you do is, come check it in another assay, because actually the commonest problem is actually an assay problem. If T4 is high, you should always have a suppressed TSH. If it doesn't, then this is discordant thyroid function testing, and then you have to approach it differently. And as I say, I've got two cases tomorrow, which is dealing with this exact scenario.
Also about the total thyroxine, because if the total T4 is high, the other condition like an estrogen therapy, those things we need to remember. So better to check a free T4 in those situations.
That's right. Another question, is it better to take thyroxine tablets at bedtime for better complaints?
I think Prakash has already told that, and there are some data that are coming that 4 hours fasting is good enough, but I think we don't want to give this type of still not very clear information to the practicing clinicians and to the patients. So we all the time take the fasting in the morning, even before getting up from the bed, you can take the tablets. So give a gap of at least 30 to 45 minutes. Other than water, don't take anything. That's what sort of standard practice, and I still go with that because I don't want to spread this knowledge to public that you can't take the thyroid tablet any time of the day, take in the night before going to bed. And it can work for Prakash because the dinner, as traditional in England, is by 6 o'clock, 6:30 is over. But our dinner is at 10 o'clock, 10:30, 11, people are taking dinner. So where is waiting for 3 hours after dinner, it will become early morning. It's better to take before you get up then.
Now, it's a very funny question. What's the maximum dose of thyroxine?
To Prakash.
Well, I mean, it's usually compliance issues. I mean, I've seen doses. For example, the case I used was 450 micrograms. So that is usually a compliance issue. I think I've seen even higher, 450 or even I think 500 I have seen. But quite often it is patients not taking it. And when you drill down to it and when you do the absorption studies, you actually find, so that patient went from 450 to an average dose of 150, 200. But it's getting to that stage, you need to go through the absorption studies and that. In reality, you would, anything over 200, you should be investigating as to why it's over 200.
Yeah, that's a good message. I think for us it is important. So anybody requiring more than 200, we should think something whether compliance is correct or not. Very nice. Yeah.
And another question, very funny question: the elderly individual and no symptoms, TSH more than 65, low T4. How do you approach? Elderly individual, no clinical symptoms, TSH above 65, low levels of T4. I think there is not much scope for the discussion because patient age is immaterial. Of course, and we should go little slowly. Is that the message you want? Okay.
Yeah, I think that's correct. That's the message, that we need to start slow, start low, go slow. That will be the best company.
Very interesting question. It's a time difference between administration of levothyroxine and carbamazepine in a patient with a hypothyroidism and seizure disorder. Arpanji.
In Prakash's slide showed 1 hour. It's correct now. Within 1 hour, no tablets to be taken. I think we will follow that. Very clear message.
I think all other questions are very simple questions. I think that's all. The questions are okay, and I think we have done. We had a very beautiful sessions by Dr. Prakash, Dr. Sheila, and Arpanji, and they have did the justice to the topic. I think there is a time to close the session. With this, I thank all the speakers, Prakash sir, Sheila ji, Arpan sir, and special thanks to McLeod Pharma, and over to Mr. Ganguly for the closing remarks. Thank you very much for the chance given to us.
Fine, thank you, sir. It was a very interactive session. I think we had almost 1,200 doctors who had actually joined us, and definitely it was insightful. It was definitely informative, and thank you, Dr. Prakash, Dr. Arpan Dev, and Dr. Shaila had to leave, and especially thanks to Dr. Jabbar for really chairing the session with such elegance, and like the flow was so smooth, and to top it up, we managed to meet the deadlines of the whatever we had set, sir. It is a very it's a very privileged and an honorable thing to really chair such a session which was there with so good eminent speakers which were there. And thank you, Dr. Jabbar, once again. For the doctors who are there, sir, we would like you to again rejoin tomorrow. Dr. Prakash Abraham will continue his session. He has presented 5 cases, and tomorrow we will have another 5 cases which he will be presenting. On top of that, we will be having 2 more speakers. Then we will be having sessions which are there on diabetes and on disease, how to treat with elderly and with thyroidism with cardiovascular comorbidities. So these are very interesting topics which we will be addressing tomorrow. And I think we had a good 1,200 people is quite good for a session like this, because most of the doctors have got bored of the online CMEs. But in this context also, if we have 1,200 people joining us, I would say that we definitely had a good definitely speaker list which was there, and that is why we had such a good number joining us. Thank you, sir, once again for really hosting, and thank you, sir, for giving such an informative session. And just to remind you that this was a part of Thyrox CME. We had this is the first year that we have started off this medical session, and we would like to continue it. And this will be more informative in the times to come. And definitely, we would like the support of you doctors, and definitely we would be going ahead with such more informative topics. Thank you once again, sir. Please, and do stay safe. And definitely, this is a COVID times, and hopefully we will be meeting again face to face in the times to come. Thank you once again.
Okay,
thank you, sir. Thank you. Good night. Good night, sir. Good night. Good night, sir.
Hello, sir. Raghu.
Yeah, Raghu. You're disconnected?
Yeah. Everybody is logged off, so we're just
Okay.
there. Dr.
Beautiful
Sanket,
session, sir.
Yes, Dr. Sanket, how was it?
It was beautiful. It was nice. I mean, they touched upon many aspects. The case presentation was really exciting and something
this-
new on the plate. I think that would have made a difference to
That's
the
why we-
attendees as well.
Kept it as a case based because भाषणबाजी तो हर कंपनी कर रहा है, so some few cases से अगर किया है तो फिर that is the difference which was there. So Dr. Shaila was slightly, she got that मेरे को questions क्यों नहीं पूछे लोगों ने, so that is why. So unless the questions नहीं होगा, मैंने वही बोला that madam you must have explained it in such a way that they did not have any questions.
चलो, ये बड़ा अच्छा था sir. It was a good something different than the usual the way symposiums run. So the case based approach was nice. अच्छा था.
Chalo, next tomorrow also we will have almost similar numbers. We should have maybe a little lesser because Sunday evening people want to go out, so maybe we may have a little less. But today was